This program, which we're doing with Stamford Hospital, is funded by the donations from the Friends of the Library, and we thank you very much for your support. If you are not a friend of the library and want to support these sorts of events and all of the other content we do, we invite you to take part. In just a second, I want to introduce Dr. Herbert so he can start the program off. Thank you very much, and Dr. Herbert.
Good evening, everyone. Thank you, Alan. Welcome to the Darien MedEd series. We're in fall semester 2016. This is the third of 5 lectures. I see some familiar faces, so welcome back to those of you who have been to the other lectures. Tonight we'll be discussing concussions. The following 2 weeks we'll cover health and diet and dermatology. Just to go over the rules, we start at 7, we finish at 8:30. I want to thank the Darien Library for hosting us this evening and hosting us for the whole series. The format for the lecture is 1 hour of lecture followed by 30 minutes of question and answer period. And just to remind everybody, this is a collaboration between the Darien Library, the YMCA of Darien, and also Stamford Hospital, specifically the Physician Relations Department. So thank you to all of those organizations. My name's Josh Herbert. I'm the moderator for the program. I welcome you. I have been on staff at Stamford Hospital for the past 17 years. I'm a primary care physician, and I am the current president of the medical staff at Stamford Hospital. Christina Kunec is the director of the Stamford Health Concussion Center. Dr. Kunec is a clinical neuropsychologist and leads a multidisciplinary team of clinicians to provide complete continuum of care to patients. She is responsible for conducting neuropsychological testing as the basis for guiding the appropriate treatment of pediatric and adult patients diagnosed with concussion. Dr. Kunec received her doctorate in psychology at the Institute for Graduate Clinical Psychology at Widener University in Pennsylvania. She also holds master's degrees in clinical psychology from Widener and in general psychology from American University in Washington, D.C. Prior to coming to Stamford Health, Dr. Kunec completed her neuropsychology fellowship at the University of Pittsburgh Medical Center Sports Medicine Concussion Program. During her training, she provided clinical care and conducted research on sports injuries with elementary school children as well as professional athletes. A member of the American Psychological Association, American Academy of Clinical Neuropsychology, and Sports Neuropsychology Society, Dr. Kunec worked in epidemiological research for the National Institute of Mental Health as well as Harvard Medical School. She's co-authored several papers and is a frequent lecturer on the causes, management, and treatment of concussion. Please join me in welcoming Dr. Christina Kunec.
So you have to be living under a rock to not be aware of all the attention that's been on concussions recently in the media, in the schools, probably among friends and family. And so tonight I'm hoping to introduce you to concussion, explain exactly how we diagnose concussion, different ways that we evaluate it, as well as manage and treat it. So the objectives for tonight's talk are to provide background information regarding concussion evaluation, to review the utility of neurocognitive testing as a tool for effective concussion management, to review treatment and rehab protocols, and to also present you guys with some data pertaining to risk factors and outcomes associated with sports concussion. So what is a concussion? A lot of people actually don't know when I ask them. So a concussion is a complex pathophysiological process affecting the brain, and it is induced by traumatic biomechanical forces secondary to direct or indirect forces to the head. So contrary to popular belief, you actually do not have to strike your head to get a concussion. You can get it from an injury such as whiplash, where there's a force to the head. Disturbance of brain function is related to neurometabolic dysfunction rather than structural brain injury. So if you were to take a picture of the brain with an MRI or a CT, it's typically normal. It may or may not involve a loss of consciousness. In fact, the majority of concussions, about 80 to 90%, do not involve loss of consciousness. And I try to convince insurance companies of this all the time. The concussions result in a constellation of physical, cognitive, emotional, and sleep-related symptoms. and we'll talk about that in more detail. And recovery really is a sequential process, and we know symptoms can last from minutes to days to much longer in certain individuals. So in terms of the biomechanics, I talked about these forces that are directed towards the brain. So there can be essentially two types of forces. There can be these linear forces, which are more forces that would occur in a deceleration injury. So you're traveling in your car, you stop short, maybe you ram the car in front of you, or you hit the car behind you. And in this type of force, it could also be a helmet-to-helmet hit in football. The brain is moving forwards and backwards in the skull. And so the front part of the brain, the frontal lobes, is bumping up against the front of the skull. And then there's also kind of a rebound, what we call a contra-coup effect, where then the brain moves backwards in the skull and the posterior region of the brain pushes up against the back of the skull. There's also what we call a rotational injury. And these are the injuries that we see in the unsuspecting athlete who's maybe blindsided. And in this type of injury, there's actually acceleration of the head around the midline axis. And these are much more dangerous and more likely to result in concussion when this force is directed from the side. So in the second one, the brain actually kind of twists around the midline axis versus the forward and backward one. So during the last decade, emergency department visits for sports and recreation-related traumatic brain injuries, including concussions, among children and adolescents has increased by about 60%. So this suggests that approximately 1.5 to 3.8 million sports-related concussions are occurring each year. It's actually the number 2 cause of traumatic brain injury in individuals between the ages of 15 and 24 after motor vehicle accidents. And the numbers and rates are highest in football and girls soccer, which is hopefully not terribly surprising. For males between the ages of 10 and 19, sports and recreation-related TBIs occurred most often while playing football or bicycling. And for females, the same age group, most often occurred while playing soccer, basketball, or bicycling. Who knew riding a bicycle was so dangerous? So here we have a normal neuron. So a neuron is essentially a brain cell, and we have billions of them in our brain. And these brain cells send signals to each other. And one brain cell talking to another brain cell is what controls essentially how we function, how we think, and how we feel, and how we act. And so the brain cell receives a signal that arrives at the dendrites, and it travels down what we call the axon to another cell. And what happens is when the signal gets to the end of the axon, something called neurotransmitters are released into the synapse. And they're released in an organized manner, and basically it triggers the next cell with a specific coded message. But what happens during a concussion, so we know that there's, again, movement of the brain inside the skull, right? And what happens is those brain cells, those neurons, the membranes of them actually get stretched out. And when that happens, potassium, which is normally inside the cell, rushes out of the cell. And when that happens, there's this increased demand for glucose, which is like energy. And at the same time, because these membranes are stretched out, calcium, which is normally outside of the cell, goes into the cell. And when this happens, there's vasoconstriction, so there's actually decreased blood flow at the same time that the brain is calling for more energy. So this results in essentially an energy crisis, and this is how I explain it to my patients. So basically, the brain's calling for more energy, it's not getting the energy that it needs, and during this time, the nerve cell is extremely vulnerable. And so we want to make sure that there's no secondary injury that can occur during this time frame, which could result in potentially cell death or more cell damage. So it can take days or even longer for these nerve cells to return to their normal condition. But during this time, there's really this interference with these brain cells communicating and sending signals to each other. But after days, things start to go back to normal. Calcium goes back out, potassium goes back in. And after many days, we get our normal neuron back. And so this is important because it's important to know that concussions, for the most part, are a very manageable injury, and they are an injury from which most people fully recover from. So when we talk about the signs of concussion, the signs are things that are observable by a bystander, so a parent at a soccer game, a coach, an athletic trainer. And there are what we call immediate markers, so things that you would notice immediately. So things like loss of consciousness, I think we all know what that is. Retrograde amnesia, which is difficulty remembering events leading up to the injury. So you're on the field, you kind of, you don't know how you got there, you don't remember dressing for the game, you don't remember the ride to the game. There's anterograde amnesia, which is what we consider post-traumatic amnesia. So this is difficulty forming memories after the injury has occurred. So the individual doesn't remember coming to the sideline or going to the hospital. So there's two types of amnesia. And disorientation and confusion, kind of what it, it says what it is itself. It's basically not knowing where you are, being confused as to what happened, how you got there. Then there are symptoms. And so the symptoms can actually present days or even a little bit longer after the injury occurs. They don't all necessarily present right at the time of the injury. Sometimes it's not until an individual goes to a different environment that some of the symptoms come out. And so we found that the symptoms tend to cluster into different groups. So there are kind of like the physical symptoms. These are more migraine type symptoms. So headaches, right? Changes in vision, there can be dizziness, lighter noise sensitivity, nausea, vomiting, all that fun stuff. There can be just changes in sleep, so difficulty falling asleep, trouble staying asleep, sleeping less than usual. There can also be individuals who have trouble staying awake and they're sleeping all the time and taking naps. There are cognitive symptoms, and that means kind of like thinking problems. So they can be attention problems, concentration problems, trouble with memory, a sense of feeling kind of foggy, which I describe as kind of feeling almost like you're on another planet, kind of out of it a little bit. A lot of people report fatigue and just slowed thinking. And then there are kind of the emotional types of symptoms that individuals may experience. They might just feel more emotional in general. They may experience low mood, anxiety, irritability. So sometimes individuals have symptoms from one of these groups, and sometimes individuals have symptoms from all of the groups. We don't want to play around with. So if we notice that one pupil is larger than the other, if the individual is very drowsy and you can't keep them awake, they're vomiting, not just once or twice, but repeatedly vomiting, slurring their words, any type of convulsion or seizure, don't recognize familiar people or places, might be very disoriented, and loss of consciousness we want to be careful of. Okay, so the ideal concussion evaluation timeline would begin with what we call baseline testing. And this is testing an individual at their healthy state so that in the case that they become injured, we can compare that individual when they're healthy to that individual when they're injured, apples to apples. So some schools around the area provide baseline testing. We provide it at our clinic. These are the different subtypes that we started to identify. So I'll explain them in a little bit more detail, but the vestibular subtype is a subtype. So the vestibular system is a system in our brain that helps coordinate space and motion. And you really don't appreciate the system until it's not working. And with a concussion, if it doesn't get the energy that it needs to run smoothly, you may have problems like dizziness, balance problems, feeling foggy. Busy places might make you feel headaches and dizziness. Some individuals have ocular problems, so vision problems. They might have double vision, they might have blurred vision, they might report a lot of trouble with reading and math, and most people don't report that their phone ever bothers them, but prolonged periods of reading and visual activities might bother these individuals. There can be a cognitive subtype. So these are the individuals that get very tired throughout the day. They have a lot of trouble with memory, trouble paying attention. Then there are individuals that have more of this migraine subtype. So these are the people that the headache is usually their number one symptom. They might have associated light and noise sensitivity. They might be nauseous. They might be vomiting. There's the cervical subtype, which is the subtype that involves primarily like the neck. And so a lot of times the neck is affected, particularly in whiplash injuries. And then there's the anxiety and mood subtype. So these are individuals whose primary presentation might be anxiety, depression, maybe they have a hard time kind of turning off their thoughts. They might be more irritable, more edgy. And so it's nice to identify these different subtypes to try to figure out where the problems are coming from. Very rarely does someone fall into just one subtype. Usually they've kind of got a whole host of symptoms. But figuring out where the primary problems are coming from, again, can help us figure out how to treat them. And so I like this slide because it talks about potential risk factors, and we'll talk about that later. Then you've got the concussion, and then you see it can kind of scatter into these different trajectories. And then based on these different trajectories, there's different treatment rehab pathways. So someone who's got mood problems as their primary presentation isn't going to be treated the same way as someone who's having problems with their eyes. Okay. So the second part of the evaluation is what we call the vestibular, ocular, and balance assessment. So I explained a little bit before, the vestibular system is our space and motion system, and it helps us anytime there's lots of movement. So it could be an individual moving through space, walking down a hallway, traveling in a car, Or it works really hard anytime an individual maybe is stationary, but they're in a busy environment, like a lunchroom, a cafeteria, a sporting event, and so things around them are moving. So in both of those situations, your vestibular system has to take in information through your eyes and your inner ear to make sense of where you are in space. And again, you don't really appreciate that system until it's not running smoothly. So we know that this system is often affected following concussion. About 50% of individuals report initial dizziness, and we know that initial dizziness can lead to a prolonged recovery. 30% of concussed athletes report initial ocular problems, so it might be blurry vision, double vision. 65% of concussed patients report some type of ocular motor dysfunction, which is trouble kind of working the eyes and head in coordination. And 40% of concussed athletes report initial balance problems. And we know that any problems in these areas can lead to poor performance at school and work, and a lot of discomfort with motion or anytime they're in a busy place. And so part of our evaluation includes what we call the vestibular ocular motor screening. And this is a test that takes 5 to 10 minutes to administer, where we're basically looking at this ocular motor function. And so we look at the ability from an individual to follow a moving target. What we call it is an H test. So we have them follow our fingers and keep their eyes on the moving target. We look at what we call saccadic eye movements, which is the ability to move smoothly from one target to another. And with all of these tests, we're looking, can the individual actually carry out the task, and does it provoke symptoms? And so with these, we're looking for, does the individual report that they're feeling dizzy? Does this individual report that they're experiencing a headache? Do they notice blurry vision? And can they actually keep their eyes on the moving target? We also look at the vestibular ocular reflex. So we have individuals focus on a stationary object such as their thumb, keep their eyes fixated on the object, move their head back and forth. We see, can they actually maintain their gaze on their thumb? And does it provoke symptoms? We look at what we call visual motion sensitivity, which is a little bit more involved, where we have an individual keep their eyes focused on their thumb, rotate 180 degrees, and see, you should be able to do this and not feel dizzy. People who have a concussion whose vestibular ocular system is involved don't feel very well doing that. And we also look at what we call near point of convergence. We know that each eye essentially takes in a different image, and it's our brain that makes it one image. And so all the time our eyes are constantly working together, but sometimes when an individual gets a concussion, there's not enough energy to power that visual system, and the eyes have a hard time working together. And so a lot of times, particularly for individuals who have posterior head blows, because that's where our visual cortex is located, they'll have trouble with their eyes working together, and they might actually see double. So we look at that. And we know that people who are seeing double, as you can imagine, would have a lot of difficulty in school and in work and in any time you're using your eyes or reading. And then we also look at balance, which is not the vestibular ocular system, but more of the vestibular spinal system. And we know that balance can be affected by concussion. And so we have an individual stand in a number of different stances. We make them stand on a hard surface, we make them stand on some foam, and we look at the number of errors that they make. We find that balance is usually the quickest to resolve in terms of the vestibular system. So an individual within the first week might have some balance problems, but they're much more likely to resolve more quickly than the vestibular ocular problems, which is like the head and eye movements. And then the last piece is neurocognitive testing. Okay. And so why do we do neurocognitive testing? Why don't we just ask someone how they're feeling? A lot of reasons. So we know that brain function is affected following concussion. And we know that athletes cannot always, and not always athletes, just anyone actually, cannot always be trusted to accurately report symptoms. Whether it be motivation from a motor vehicle accident, maybe there's litigation, or an individual wants to get back to play because they've got the championship, so maybe they're more likely to minimize their symptoms. Maybe there's something else going on and an individual just doesn't want to play the sport, but they don't want to tell the parent. Anyways, we can't always rely on an individual to accurately report their symptoms. And young athletes, so children, simply lack insight into being able to assess many of their own symptoms. We know some people might minimize difficulties. Many athletes are naive to the different subtleties of the injury. And again, we're asking somebody with a mild brain injury, we're relying on them to tell us how they feel. So we need some objective measures. There have been some studies out there that suggest that up to 50% of athletes experience concussion symptoms per year, but only 10% actually report having an injury. So we really need this comprehensive understanding of the athlete's recovery status. And so by doing what we consider neurocognitive testing, we're testing a range of different cognitive abilities, memory, attention, speed of information processing, reaction time, and we can examine different patterns of performance in different cognitive areas, so different parts of the brain. And based on that assessment, we can, again, make an inference on where some of the problems might be coming from. So when we do computerized neurocognitive testing, we consider it to be one tool in our toolkit. It's one tool to help us to determine whether an individual is recovered from an injury or whether an individual is progressing, whether or not they're not progressing. It's also a nice tool to help us to communicate post-concussive status to the athlete, to the parent, to the coach, to the teachers in some cases, or school nurse. And we know that it's very useful in identifying deficits regardless of whether or not an individual is open to reporting their symptoms. But it's not a substitute for a medical evaluation or treatment by itself. It can't stand alone as a diagnostic test. It's not a preventative tool, although we know that baseline testing can certainly help us to distinguish how impaired an individual may be. It's not a home-based test, so you should never be taking this test at home, which some schools out there still do. And it's not a sideline evaluation tool. It's something that you would do probably 72 hours post-injury in the athletic training office, at the school under the supervision of the nurse, or in your clinician's exam room. And, well, I didn't realize how big that was going to get. Interpretation of the results really is critical. So you need someone who's looking at these results who really understands the different aspects of neurocognitive functioning. It's not a pass-fail test. So again, the data that's gathered from the neurocognitive testing is used in conjunction with the interview and that physical exam that we do, the vestibular ocular screening, to make recommendations. And it helps us figure out how much cognitive exertion a person can engage in. Do they need academic accommodations or work accommodations? How much physical exertion an individual can engage in? Whether or not we think that they might need to see another clinician for medications, whether or not they might need physical therapy or vestibular therapy or vision therapy or even more extensive testing. And I wanted to throw this in there. The baseline testing, as I mentioned, is testing an individual on all these levels when they are healthy. That way, if an individual becomes injured, we have a picture of that individual in the healthy status, and we can compare apples to apples. And it's not only helpful for an individual who maybe has a history of a learning disability or ADHD, who maybe learns a little bit different to begin with, but also for individuals who are overachievers who do very well in school, because if we have a picture of them when they're healthy, and then we take a picture of them when they're injured, maybe they're falling in the normal average range, but maybe that's not normal for them because they are so high achieving. Does that make sense? So we're comparing apples to apples. So going back to the injured individuals, which are primarily the ones that we see in clinic, it's very important to understand the symptoms and understand that a concussion affects everybody differently, and everybody, there's huge individual differences. So one person might feel one way, another person might feel another, and so you can't treat them all the same. Again, we know that the symptoms might be cognitive, somatic, sleep-related, emotional. They can worsen with cognitive exertion, so thinking and concentration, as well as physical exertion. They can wax and wane throughout the day, and it's hard because a lot of times these individuals may not even look or act injured. Excuse me. So I have a lot of students in school, it's almost like they feel like they need to have like a cast or something wrapped around their head, or wrap around their head, because it's not like they have like an injury that's visible to other people, to their classmates, to their teammates, and to their teachers. So sometimes they have a hard time reminding the administration that they're actually still suffering. And so the traditional, I threw this in here, my husband loves Homer Simpson. So the traditional protocol was what we consider rest and wait. And so there's a lot of people out there that prescribe what we call cocoon therapy. It's like sit in a dark room and kind of wait for your symptoms to go away. But we know that doesn't work for everybody. And as you can imagine, especially in a town like Darien, where there's a lot of people who are very successful. They're high achievers. They play a lot of different sports. They're very involved in the community. They're hard workers. If you tell someone to just kind of relax and sit in a dark room and do nothing, they're going to go crazy. And so we know that, especially for students who are in school, pulling them out of school for extended periods of time is not always the best bet. And so the sitting around resting and waiting is not necessarily the best approach to recovery. And there's been a lot of research to support this recently. So the practice guidelines recommend that there's an initial period of rest for a concussion or mild traumatic brain injury. But there's been compelling evidence out there that other health conditions even can be worsened by inactivity. And so those are things that might be improved by moving around and exercising. So the evidence out there, the best available evidence out there, suggests that rest going beyond 3 days is actually probably more harmful than helpful. And that an individual should gradually resume their pre-injury activities as soon as they really can. And that supervised exercise, so supervised by a physical therapist or an athletic trainer, might actually benefit patients who are taking a little bit longer to recover. And so they did a study out there, and they had individuals who were concussed, and they prescribed what they call strict rest. That was rest, people who were told to literally do nothing for 5 days versus those who were told to rest for a day or two and then kind of start getting active again. And they found that there was no clinically significant difference in the neurocognitive outcomes, and that the intervention group, so the group that was prescribed the strict rest, reported more post-concussion symptoms, and they had a slower symptom resolution. And so they concluded that this strict rest, particularly for adolescents, right after a concussion, really didn't offer any added benefit, and that their symptom reporting was actually influenced more by recommending the strict rest. So a lot of what we teach is behavioral management. Certainly when an individual is injured and recovering from a concussion, we don't want them to engage in any group or contact sport activity. We don't want them to be in any situation that poses a risk for re-injury. So sometimes I have to explain, no, you can't play in your ice hockey game this weekend, but you also really shouldn't go skiing. So sometimes there's a disconnect there. And so no activity that poses a risk for re-injury. We really want to keep physical activity minimal until there's a reduction in symptoms. And so if the symptoms are 7, 8, 9, 10 out of 10, we don't want to do too much physical activity. The goal is to kind of get better control of those symptoms and bring them down to a mild level. We want to reduce cognitive activity. So a lot of times we have to make adjustments to an individual's academic or work schedule. We'll give them accommodations. Maybe we recommend that they go half days, cut back their hours. We want to do reduced stimulation. So we recommend, limiting video games, computers, phones, tablets. Very rarely do I say that an individual can't look at a screen at all, because that's just very unrealistic. Especially for students these days in school, they're using the iPads and the computers for everything, and someone in the work environment is using their computer and checking their email all the time. So we say if you need to check in and then check out. Don't spend extended periods of time on the computer or on the phone. But we really want to overall try to reduce that stimulation. And then again, as I mentioned, we're kind of shifting from this model of complete rest to one of more managed activity. Can you read that? It's kind of small. So we recommend, even in the beginning, really light levels of physical activity. I tell individuals, even within the first week, you should start going for a walk. Maybe you can shoot hoops in your driveway, play catch with someone that's got a good throw, who's not going to hit you in the head. Controlled exercise. So they do a little bit of activity, but below the level that starts to really trigger symptoms. So if their symptoms are minimal and they know they can go for a 10-minute walk, but after 20 minutes their symptoms really start to spike, well then they keep it at 10 minutes. Again, it's optimizing activity without overexerting. And this goes for physical activities and cognitive activities such as school and work, and social activities and anything that might stir them up in that way as well. So it's kind of like finding that sweet spot where you can do a little bit of activity, but then when you stop you feel okay and you don't feel your symptoms spike. And we know in particular this helps in cases of migraine and for any individuals who might be experiencing problems with mood or anxiety. Because again, telling someone that they can't do anything and they need to sit and rest and sit in a dark room until their symptoms go away, in a lot of cases can stir up anxiety and make people stressed. So there's different treatment interventions, and I talked about a number of these. So one of them is managing the environment, right? Giving an individual some accommodations for school or work, and telling them certain things that they might need to avoid. We have actual therapies, physical therapies that can help. So we have vestibular therapy, which is physical therapy by physical therapists who specialize in the area of like neuro rehab, and they actually help people rehab that vestibular ocular system. There's actually specific vision therapy that can help an individual who's got double vision. There's cognitive therapy, which can help individuals develop like compensatory mechanisms to get around memory problems or trouble paying attention. There's graduated exercise approach. Education is key, and so educating individuals and their families about what is normal, what's to be expected is essential. You will continue to probably develop headaches for a bit. They're not just going to go away necessarily, tomorrow, but that what you're feeling is normal throughout the recovery process. Medication in some cases is warranted. Pain management, certainly. We educate a lot about sleep and sleep hygiene. Many people do not get the sleep that they need at night. Many people are napping during the daytime, and we know that that can throw off the sleep schedule at night. And then for individuals who are really experiencing these emotional symptoms and they're having a hard time controlling the stress, the anxiety, or maybe the depression, in many cases we involve psychotherapists for that. And so looking at all this, based on this, you can see that it really takes a village to treat this injury. You really need a team of experts to treat this injury. Not one provider with a background in one area can treat this. And so at our center, we have neuropsychologists, we have neurologists, we have people who specialize in pain management, we have physical therapists, we have psychotherapists. So it really takes a team. You really need what we consider to be a multidisciplinary approach to treating this injury. So I didn't mention this before, but headaches are present in about 70% of people with concussion. It's like the number one symptom. And so I like this because it talks about ways to manage headaches. And so if you think of headaches essentially as a threshold, so if you cross the line, you're going to get a headache or a migraine. And there's things that can bring you closer to that line. One of them is a personal history of headaches and migraines, or maybe you have a family history, because a lot of times migraines are hereditary. So those are things that might bring you closer to that line. But what happens, let's see if I can do this without messing it up, when you get a concussion? Well, chances are you might have dysregulated sleep. Maybe you have a hard time sleeping, maybe you're sleeping all the time. You're probably not exercising quite as much as you used to. You're probably dehydrated. You might not be feeling well to eat. And you're probably a heck of a lot more stressed out. Those are all things that could pop you over that line to getting a headache. And so part of the education piece is really emphasizing the importance of keeping a regular sleep pattern, keeping a regular diet, making sure that you're eating breakfast every day, making sure that you're staying hydrated, doing some form of light physical exercise, and managing stress. So that's something that I educate patients about pretty much every time I see them. And it sounds basic, but a lot of times it really can make a difference. So everyone wants to know, what does it take to get back to play? There's a number of things that have to come together. Number one, an individual needs to be back at school or work full time, and they can't be getting any extra help for the concussion, so no extra accommodations for the concussion. In terms of physical activity, we want to see that the individual has progressed from light levels of activity, like walking, to more moderate levels, to actually heavy levels of activity. And if an individual is an athlete, we want to make sure that they actually try some of their sport-specific activities to make sure that they still feel okay. Because we want them to be completely symptom-free at rest, but we want to make sure that they maintain that symptom-free status with physical exertion. So I want a soccer player to be able to go to practice and even head the ball to clear them, because if they can't head the ball without getting a headache, then they're not recovered from concussion. When we do our evaluation, we want to make sure that they're not having any trouble with their head and eye movements, that their balance is back to normal. And when we do the neurocognitive testing, we want to make sure that that's back to either baseline, if they have a baseline, or expectations based on where we would expect them to fall based on their academic and medical history. So those are all the things that need to come together to clear someone back to play. So I wanted to present a little bit of research on recovery, because everybody wants to know how long it's going to take. And the answer is there really is no easy answer, but most of the research is done on male high school football players. And in this population, they found that about 80% recover in about 3 weeks, regardless of whether or not they've had a prior concussion. And so that's what I tell most individuals. In about a month, most people are recovered. Certainly we see a lot of individuals for whom it's taking much longer. There are certain things that make someone a little bit more likely to have a complicated recovery. And so an individual who's maybe got a history of concussions, and this is especially the case for individuals who maybe didn't receive the proper treatment and maybe they weren't actually 100% recovered before they got another injury. So maybe this second injury that we're seeing them for is actually an extension of the first. A history of migraine might make someone a little bit more likely to have a complicated recovery. I say that migraine is kind of like the evil cousin of concussion, but a family history of migraine, a personal history of migraine, it's likely an individual with this will take longer to recover. Any individual who's got a history of maybe developmental or neurological concerns or emotional problems, or a history of space and motion sensitivity like car sickness, or ocular problems like amblyopia, which is like lazy eye. So if we think of a concussion, remember, as this energy problem that happens in the brain. And so if there's anyone that maybe they have a part of their brain that they have to work a little bit harder for, whether it's managing migraine or they have an ocular issue or spatial motion sensitivity, so maybe their brain has to work a little bit harder to manage that problem. When they get a concussion, a lot of times those problems become heightened or exacerbated. So I like to say that concussion fights dirty. So if you have a weakness, concussion's probably going to bring it out because it's an energy problem. We know that younger individuals might have a more complicated recovery. Their brains are still developing. Younger individuals have weaker neck strength. They're kind of almost like human bobbleheads. We know that females are more likely to have a complicated recovery because we're more honest. So we're more likely to report our symptoms. We have weaker neck strength and we're more prone to migraine. And then there are post-injury factors, so things that can happen afterwards that might affect an individual's recovery. So number one is access to care. So depending on insurance, unfortunately, an individual may not be able to get to the treatment providers that they need. There may be other injuries that occurred in the accident that maybe impede the recovery model. So if someone got a concussion but they also broke their ankle, well then it might be taking them a little bit longer to get up on their feet and start walking again. I think I mentioned if an individual has migraine, then they're more likely to have a protracted recovery, but some people also develop that post-migraine, post-traumatic migraine subtype, and that can complicate things. We know that if an individual has dizziness immediately following their injury, or fogginess, so it's that sense of kind of feeling like you're on another planet, might take longer to recover. Individuals who aren't educated about what to expect, a lot of times take longer to recover. And then we have developed cutoffs on neurocognitive testing. And if an individual falls below these cutoffs, or they basically fall a number of standard deviations below their baseline, there are numbers that we can calculate to figure out that they might take longer to recover. And by protracted, we mean more than 3 weeks. Interestingly enough, brief loss of consciousness, so loss of consciousness for just a few seconds, is actually not predictive of a protracted recovery. So sometimes an injury that looks really scary initially doesn't necessarily mean that they're going to take longer to recover. And that's why we actually don't use the grading systems anymore for concussion, because I see some people who've had brief loss of consciousness and they're back in 2 weeks. And then an individual who didn't lose consciousness and had an injury that you might think would be minor, who takes a lot longer to recover. So these are the top 11 symptom predictors of protracted recovery. So number one is fogginess, followed by difficulty concentrating. So if an individual is reporting these symptoms, they're more likely to have a protracted recovery. Vomiting is in there, obviously, followed by dizziness. These implicate the vestibular system, and that system, the space and motion system, a lot of times needs physical therapy to rehab. And so I wanted to cover this, like I started out my talk. You'd have to be hiding under a rock not to hear about concussions. But I get a lot of individuals in the office who, think that a concussion is kind of like the worst thing that could ever happen to them. There's almost like this hysterical aspect that's been built around concussion, and I blame the media for it. And in the media, there's a lot of emphasis and stories about like these worst case scenarios. And there's a lot of concern out there about developing CTE, which is chronic traumatic encephalopathy. It's what you hear some of the individuals like Fred Gifford had. And the bottom line is there's a lot of misinformation out there. And the truth is that the sky is not falling. There's a lot more focus on concussion. And I think that the pendulum has actually swung from there not being enough focus to there actually being like too much focus. Believe it or not, I actually see individuals in the office who don't have a concussion, but because there's so much focus on it, they see us and they didn't even hit their head. And so I think it's important that individuals, coaches, anyone who's dealing with athletes and students really get the proper education out there on how to recognize the signs and symptoms, but then also understand that this is a very manageable, very treatable injury, and so getting into the right treatment team and getting the right information in the beginning can really significantly affect outcome. And so we know that concussions happen, we know that they can be complex, but we also know that they're very treatable and manageable. And that we know that a multidisciplinary approach is essential, and really no one provider can manage it all. And communication among the providers and among the, back and forth between the school, with the athletic trainer, with the coaches, is really essential to get these athletes and these individuals back to play. How did I do for time? Oh, not too bad. Do you guys have any questions? That was a lot of information. I could talk about this all day long. Yes?
What's the ratio for car accidents? I mean, it's always about sports. You don't hear about car accidents, how concussions.
Certainly see a fair amount of individuals who have had car accidents. Most of the younger population that we see are sports related, but the adult population that we see are primarily car accidents and falls.
Because I broke my neck in a car accident in 1990, and I was partially paralyzed for a year or so. And they never mentioned to me that I might have had a concussion, and it was always, I was in the hospital for 7 weeks, so I guess I kind of moved by it. But I was never, when I talked to my doctors for the next 2 years, they never said, hey, you had a concussion.
Right now, they probably would,
Now they would, because
but
1990 they didn't.
Right, yeah, the focus is much more on concussion now, I think, than ever before. It used to be like, how many fingers am I holding up kind of thing. And now the coaches and athletic trainers have to go through extensive training to be able to treat that in the athletic field. But not as much necessarily, in the physician's office so, yep.
Has there been any research into like the very long-term effects of a concussion, let's say years later, especially if it wasn't properly treated?
So that's the research that's really ongoing right now. And we certainly see individuals who, we treat primarily the acute injuries, but we certainly see individuals who've been years out, who've never really gotten the proper treatment. And they do respond to treatment, but it's almost like, if you broke your hip maybe and it kind of healed, but you're walking with a limp, it's hard to kind of get it back the longer it's been. But it's not to say that you can't see any progress. But the research on the long-term effects is really what's been going on now, because the focus on this has really only been over the past, I would say, 10 to 15 years. And so there are a lot of unknowns out there still. Yep.
Yeah, fascinating discussion about the aspects of concussions. I didn't really think about all of the different dimensions of the injury itself.
I know, I do this all day long, so.
But most of the treatment for what will help cure and make a concussion symptom better seems to be time. There really isn't like if you, break your arm and it's immobilized, that physical therapy is going to be loosening it up. That will help stretch the muscles. But with a concussion, aren't you just still largely saying you just have to wait? I know that you don't recommend inactivity,
Right.
but it's mostly time heals.
In some cases, but not in all cases. So in individuals who have that space and motion sensitivity, if that system's not properly rehabbed through physical therapy, they may feel better but never actually get back to normal. In individuals who have problems with their vision, they might compensate but not completely get back to normal. And so there are active treatment strategies that can actually fix this, that the body learns to compensate over time, but not necessarily get everything back nicely cleaned up. And so the individuals who are not receiving the treatment and time has helped a little bit, they're the ones that are more likely, if they get another injury, to end up way worse because they're not 100% recovered.
Well, you had said earlier in your presentation about this potassium and calcium,
Mm-hmm.
one going in, one going out. Is that the root cause, and is that what time?
That's what happens
therapy
initially.
fixes?
That's what happens initially, and then that should go back to normal, but it depends on every individual. So it can, yes, in some individuals, it can take days, weeks, months. And a lot of times, that's gone back to normal. It's almost like if you think about a concussion as this like storm that's passed through. So maybe the brain cells are back to normal, the neurons are back to normal, but you're left with picking up the pieces. And so it's teaching the vestibular system how to work again, and that movement is normal, and moving your head and eyes together is normal, and teaching the eyes to work together again. And so in many cases, time helps, but it doesn't help in all cases, especially for individuals who maybe have an emotional component too, and they're held out of school for prolonged periods of time. That doesn't seem to work very well. I've seen kids who've been out of school for like 6 months at a time, and it's very hard to get them back in school and caught up, because then at that point the concussion's essentially better, but a lot of times you're dealing with an individual who's extremely anxious and stressed out and possibly depressed. So it might not even be concussion anymore, it's like an artifact of the concussion. So we have very active treatment strategies out there that I think a lot of people are unaware of. It's not just sit around and wait. Time helps in many cases, but it's not always the answer for getting individuals back 100%. Mm-hmm.
I think you mentioned something about the blood vessels constricting that might lead to cell damage. Is there a possibility that the trauma is really big and then it leads to the constriction too much that you may end up in like a stroke of some sort, but they misinterpret it as something else? Or is that not really?
Well, with a strict concussion, this is what happens, and a strict concussion does not have any structural changes. But in certain individuals, they might have had a stroke, they might have had a more severe injury like a skull fracture or a brain bleed, and so they're seeing like the neurology department and neurosurgery, and then I see them later. But the process that occurs with a strict concussion is not going to lead to a stroke. And people kind of panic sometimes when you tell them what kind of happens with the concussion. And I tell people too, people get nervous when they experience these symptoms and they try activities and their headache gets worse. And I have to tell them, you're not going to cause yourself damage, aside from hitting your head again. But you are pushing systems that are trying to recover. And so when you push those symptoms, the symptoms are going to come out again. And so you're prolonging your recovery if you continue to push and not take a break and rest. But you're not gonna like give yourself a stroke or something like that.
When the impact happens.
Not with a strict concussion, no. Mhm, yep.
Oh, I was gonna say, as a parent of athletic kids, do you go with the old one and done? How do you evaluate? Are you gonna let your kid back in there and get hit again for a second?
So there's no magic number.
I know. So do you evaluate it on the seriousness?
It depends. Well, it depends on the individual, right? It depends on their medical history. If you have a kid that has got a history of migraine and learning problems, and maybe if there's kids that are more vulnerable and they get a concussion and it takes a really long time to recover, you might think twice about having them go back to a contact sport. But if they're a kid that really doesn't have any risk factors, they recover in a couple of weeks, they're 100%, they've gone through the protocol, then I wouldn't have any second thought about it. It really depends on their medical history, kind of like what they bring to the table, how serious their injury was, how long it took to recover, and then balancing the benefits and the risks of playing a contact sport. So.
Another question I have for you is, what do you think of the apps that you can have on your phone, the ones that you can actually do almost like after your child's been hit and you go through?
To track the symptoms?
Right.
I think that they can certainly be helpful at gathering the information to bring to your clinician, but I wouldn't want someone to try to diagnose or assess on their own.
The one that I've had, it'll say, call 911. I mean, you can go through certain things, and you're doing yeses and nos, and it kind of tells you, and I'm like, is this over the top, or do they?
Yeah, I mean.
It just depends.
Yeah, I mean, and if it's for your child who's playing a sport, I mean, I would look to the athletic trainer and the coach to be the ones that would, provide the main. I mean, those apps I would hope, if anything, would be a little bit more conservative, so more likely to tell you to go to the emergency room. But those red flags that I mentioned are the things that are signs that there might be something else going on. But I mean, if nothing else, those apps can be helpful at recording symptoms so that when you go to your doctor, you can say, oh, we noticed this initially, and so-and-so is having a hard time remembering the words initially, or they didn't know where they were initially, or something like that. Yep.
You talked about the two different kinds of back and forth and then the
Mm-hmm.
rotational. And I presume that it's the brain cells that are directly affected by it that suffer that, not all of them. Are there different symptoms and different outcomes from the two different kinds of injuries, so that the more complex rotational one is more likely to have something as opposed to the back and forth?
Yeah, I don't know if there's too much research. Well, so with the rotational injuries, because there's more likely to be stretching and shearing of the neurons, they're more likely to result in a concussion to begin with, and more likely to involve more systems. So those might be the more complicated patients versus the forward and backward motion. I don't know if there's that much research that talks about the mechanism of injury. We should do a paper on that, Michelle. But just anecdotally, a lot of individuals that have those posterior blows, or the unsuspecting athlete, tend to have more vestibular ocular problems, and those are the people that likely need physical therapy to help them get better.
And just one other question.
Yeah.
You said that female athletes are somewhat more likely to get it, in part because of weaker neck muscles. All things being equal, would it help an athlete to develop his or her neck
Yep.
musculature and
Yep.
any other things that an athlete can do?
It certainly, there's actually like kits out there that you can work to develop neck strength. Because yes, the neck kind of is a shock absorber in a sense, and if you have a weak neck, then you've really got a big bobblehead there. But yeah, I mean, and a lot of it is teaching these, and I keep bringing it back to athletes because that's primarily who I see, teaching these kids, the proper technique in playing these sports, how to hit, how to take hits, how to head the ball. Education in learning how to engage in these sports and the different techniques is really important, and actually exposure at an early age can help them develop those parts of their brain that they need, like head and eye movements and hand and eye coordinations. And so some people say, there's a lot of debate out there in terms of when, you should let your kids play contact sports. But to be honest, it's the kid that goes out their junior, senior year for football that's never played before that's more likely to get hurt. And so it's kind of balancing, when you introduce these individuals to the sport, but learning the proper technique, and also enforcing the rules is really important, which is up to the coaches and the organizations. Yes?
You mentioned about the neurons sort of snapping apart and creating
They get stretched out.
stretched out. Okay.
They should go back.
Right. So for example, if somebody though is, say, an aerial skier or a high jumper or a pole vaulter or something like that, where they're not necessarily, clashing like a football player against another, helmet, do you see concussions happen in those cases? Is it the
From striking the ground?
or just striking the ground even with their feet?
Oh yeah, like a
let's say
whiplash.
an
Yeah,
aerial
it can be.
skier or
It doesn't have to be a direct hit to the head. It can be like a whiplash injury.
Okay.
Absolutely. If there's enough force, your feet take it and then you whip back and forth. We see that all the time. I haven't seen many aerial skiers, but I've seen, people in car accidents who don't believe that they actually struck their head, but they got a whiplash injury. And so they might initially, the focus might be on their neck, but then after the neck's treated, they're still having cognitive problems. And, if there's enough force, if you're rear-ended by another car going 20 miles, that's more than, most people can run at you, that's enough force there to make the brain, if you think about the brain kind of as like an egg, and you're shaking up the yolk inside of it. Absolutely. So yeah, you don't actually have to strike your head to get a concussion, but there has to be force. So you can't get a concussion from standing next to a loudspeaker or being at a concert, unless you're in the mosh pit. So I see people on kind of both sides of, yeah. So there has to be, if there's enough force to your body that makes your head move at such a rate that there's movement of the brain inside the skull, you can get a concussion. Yeah. Yes?
So you talked about the potassium rushing out and the calcium rushing in. Would a baseline test, who needs a baseline test? I guess potential athletes?
Everybody.
Okay, so
Um,
where do you go for that? But also, if it's potassium running out and calcium rushing in, would the baseline test you normal? What is normal potassium in your brain and what?
The
and
base,
that way you could tell when they're back to normal and.
well, there's not really a good way to measure that, and because it's at the tiny cellular level. So the baseline test, number one, it's something that we offer as one of our wellness services. So we see injured individuals, and we also see healthy individuals who want to get this baseline. We're at the concussion center. So a baseline is essentially my post-injury evaluation on a healthy individual. So we do the neurocognitive testing. We get a sense of their memory, their attention, their visual motor processing speed, their reaction time. We look at their eyes, we look at their head and eye movements. We have them track our fingers and go back and forth between our fingers and all the things that I explained before. And then we also get a sense of their balance. And so it's looking at the different aspects of the brain that can be affected with concussion.
But there's no measuring of.
No, we're not.
Or even stretch, like how far apart the neurons are.
There's really no way to measure that. I'm sure advances in medical technology will get to points where we can. It'd be nice if there was like a blood test or something to diagnose concussion, but there really isn't at this point. And so that's why you really have to be comprehensive in your evaluation. You can't just look at symptoms. You can't just look at, testing. You need to kind of take it all in combination. Yes?
I know in soccer now, for I think female athletes, there's now a new rule that you can't hit the ball until 12 years old. What do you think of that?
Well, kind of like what I had said before, I think learning how to head the ball is important, but I do see, especially what you said, females are more at risk, right? We have weaker neck strength. With girls heading the ball and even contact football, I think that there is a case on waiting until individuals become a little bit more mature. But then are you just all of a sudden, it's how you teach the individual to begin heading the ball so that they're not scared of heading the ball, because you don't want someone to play differently because they're afraid of getting hurt either. Like I see athletes and the mom's like, well, why don't you clear them but tell them that they can never head the ball again? It's like, well, if they can't head the ball, I'm not going to clear them because I don't want them to play differently and get hurt. So I think waiting until the proper age to teach that is certainly fine. And if it's 12 or if it's 14, the problem is you line up 10, 12-year-old girls, they're all different sizes and shapes and at different stages of maturity and puberty. And so it's hard to establish like a cutoff in that way. But yeah, I don't think necessarily 6-year-old girl should be heading the ball, just like I don't think 6-year-old boys should be hitting helmet to helmet either. But so it depends. The bottom line is it really depends, but when you do introduce it, teaching the proper technique is very important. So, yes.
You mentioned a lot of things about young people playing sports. As we are an aging population, are there things that we can do to help ourselves in case we fall? Or you mentioned strengthening our neck. I fell in our driveway last year with the dog. He lurched and I fell.
Yeah.
Went for head x-rays and I was fine, but is there something we can do to strengthen our bodies to perhaps prevent something like that?
Not really. The best way to prevent a concussion is to treat it properly afterwards. It's just being aware of the fact that you can get a concussion when you fall, and not just looking at like the ankle or the hip, but taking that into account and getting in to see your treatment provider, who can then refer you. And it's initially being aware that you should take it easy, but then not locking it. It's all the education around it. But no, there's, aside from walking with like bubble wrap around. Yeah. But the neck strengthening is something that they're still doing more research on, but if you have a stronger neck, the theory is that you'll be able to absorb the force a little bit better. Yes?
Are there any statistics which can tell us how many high school kids a year get concussions in football?
So I think I said in the beginning, let me go back there with the CDC. Let's see. Oh, that's the end. That was a case that I had that I was going to do. Let's see. So here we go. So football, it's about 0.47 per 1,000 athletes. So, I mean, I definitely would say football for boys, followed by ice hockey. And apparently cycling is up there. I don't think we've seen that many cycling cases. Jill, my colleague, is here tonight. Huh?
More concussions in women in ice hockey than in boys.
Well, again, we have weaker, even though they're not supposed to, I played ice hockey. You're not supposed to check, but you can certainly get concussions. I said yes, and certainly for women playing ice hockey, because we're more vulnerable to concussions, even though women's ice hockey, you're not supposed to check.
That's true.
And I know because I played it.
Reported, concussions on women.
You know what's an under recognized population are cheerleaders? Because that's a very physical sport that I don't think I respected growing up as much as I should have. Whether you're a flyer and you're flipping through the air, or you're a base and you're catching these girls that are flying through the air, we see a large number of cheerleaders that have sustained concussions. And actually equestrians, which people don't think of, because it's like falling from a moving vehicle. So, yeah. But the big ones you hear about are girls soccer, men's football, ice hockey, the classic ones. Yep.
If someone had a large fortune that they wanted to donate to concussion research, what would you want that money to be spent on?
That's a really good question.
Chemicals to fix this nerve cells faster? Better diagnostics?
I think a lot of it would.
Physical therapy? Where should it be invested?
Well, personally, I'd like to have more physical therapists where I am, but generally, I think it would be more towards the imaging and as they get more developed with like the specialized imaging that can be done to detect some of these subtleties. More, ideally, coming up with like a blood test or something, or a scan that you could do to try to identify a concussion. I think that's where the technology is moving, and those are studies that are very expensive to conduct because of the machines that you need to do them.
That's detection, but it's not the remediation. So you're saying we're not really ready to try to do something to fix the nerve cells faster?
I don't know how you would be able to do that, but there's certain medications that can help in a sense. But a lot of it is the actual having to rehab these systems, and it's putting in the energy and the effort to go to physical therapy and to do those things. So I don't think there's like a magic wand, but that's a really good question. I'll have to think about that more. Yes.
Since there's still so much research in concussion, are there publications or organizations, or like if you want to sort of watch as a lot of this research unfolds, and you're not a doctor, how can you keep up with it, or is there a good place to
Well, the CDC has a heads up program, and they have a wealth of information. And so that's one. And then the impact test is one of the computerized neurocognitive tests that's out there, and it's the most widely used. It's what we use in our clinic, and they have a whole host of articles and sites and videos and things that you can watch out there. I would say those are probably the top two, if you're not like in the medical field and belong to like a certain organization or something like that. Yeah, don't go to whatever's on the cover of the newspaper necessarily. Or the evening news.
If you have an impact test on say a fourth grader, whether they're a hockey, soccer, football player, whatever, would you recommend having it done again prior to high school?
Absolutely. So baseline testing should be done every year until you go to high school, because your brain is developing so rapidly. Yep. Because you're comparing like a 10-year-old to other 10-year-olds, but then when they're 12, the information you have is still comparing them to 10-year-olds. You need to get a new picture of them in a sense.
I would say that coaches need to be educated more on that.
I agree. Absolutely. And that vestibular ocular system is immature in individuals that age. It really matures until you get to your teens, and your frontal lobes are developing. So it's kind of like a moving target. So you always want an updated picture. Once you're in high school, we recommend roughly every 2 years or so. But if an individual is someone who maybe has a more complex medical history, migraines, epilepsy, learning problems, I would recommend doing it every year. Yeah. Lots of good questions. Anything else? Well, thank you all for coming tonight. I really appreciate it.